Welcome everyone. I'm Zangmo. I'm part of the Living is Dying team. Thank you so much for joining for the 6th instalment of Living is Dying. Preparation for Death and Beyond. So wonderful to be doing this program together as a community. I'd like to start by acknowledging the traditional owners of country throughout Australia or wherever you're practicing from. We recognise their connection to land, waters and culture. We pay our respects to their elders, past, present and emerging. Today we'll be exploring making our wishes known, and in the coming weeks looking at a variety of other preparations including wills, cutting ties, the significance of Om Mani Padme Hum, refuge and bodhisattva vows. So planning. I didn't know advanced care plans existed until we had to do one before going into long retreat and update our wills. I did it very quickly and simply without much thought. It wasn't until years later that I realised the significance of this document. Beyond the formality of it, just how helpful to think about, reflect on and articulate our wishes. We can look at this from a Buddhist perspective, but also from a non-Buddhist viewpoint. So then we're comfortable encouraging others to talk about their values and wishes. This is part of our practice, part of our living, part of our genuine wish to benefit all beings. I've been with people facing death who have not considered their wishes or reflected on death. Others who have, but they don't share it with their family, as their family just can't cope with having the discussion. Been with a friend who had just died at home after a long illness with cancer. The ambos arrived just as she died, dragged her off the bed and started CPR. They stopped almost immediately and said to her sister, "What are her wishes? Do not resuscitate. Do you have that in writing?" "Yes." Then they apologised, saying that they didn't know the situation when they were dispatched. I actually got to witness that having instructions in place could work. A wife given paperwork to do at the bedside of her dying husband, in no position to take the information in and simply wanting to be with him. A husband asked by the surgeon if his elderly wife died in surgery. Would she like to be kept alive on life support so the family could say goodbye? He refused to discuss it and he said, "There's no need, nothing's going to happen, she'll be fine." We then did have to have the conversation with her. How could we not? A gay man's family coming from overseas when he was dying and refusing to involve his partner as they didn't accept that he was gay. Family members who disagree and fight about what they think their parents or their siblings want. So many situations, and I'm sure you all have your own examples, where things could have been made much easier for the person who is dying and those with them if we simply start talking and then documenting. Today I'm joined by Annie Whitlock, Dr. Rachel Buckley and Dr. Diana Cousins to talk through some of the aspects of planning for our death, whether it be making an advanced care directive or more informally, making our wishes known. So let's start by reading Rinpoche's guidance. Preparation for death and beyond. The Buddha said that the supreme mindfulness is remembering that death is impermanent and death inevitable. Of all footprints, that of the elephant is supreme. Of all mindfulness meditations, that on death is supreme. Some people know intuitively that their lives are coming to an end, even though they are healthy and young, and there is no logical reason for them to die. They sense that death is near. Others know they will die because they've been diagnosed with an incurable terminal disease. Unless they are spiritual practitioners, that is when most people panic, become depressed and lose hope. But instead of panicking, most spiritual practitioners recognise that death is their big chance to step up, enhance their Dharma practice, and wind down all the meaningless activities that fill their worldly lives. Whether you know you only have a few months to live or you think you have your whole life ahead of you, death is a reality that will have to be faced sooner or later. And as far as the Buddha's teachings are concerned, the sooner you face it, the better. Face the fact that you will die. Death destroys a man. The idea of death saves him. The first thing to do is convince yourself that even though you have no idea when it will happen, you will die. People die every day. We all find ourselves standing at the deathbed of a loved one at some point in our lives. Yet how many of us really believe that death will happen to us? A common reaction to receiving the news that we're about to die is to feel cheated and hard done by. Subconsciously we think, why is this happening to me and why now? I'm young, I'm not 99 years old. If I were old, I'd understand because obviously it would be my time to die. But why now? My life has hardly begun. So your first preparation for death is to convince yourself that although you have no idea when it will happen, it is absolutely certain that you will die. Secondly, you are not the only person who has ever had to face death. We will all have to die. There is nothing unfair about it. And from Dilgo Khyentse Rinpoche, whenever you think, I'm dying, visualize the Guru, Lord of Sages, on the crown of your head and generate intense faith. Then think, it is not only me. All sentient beings are subject to the law of death. No one is exempt. Although we have repeatedly undergone countless births and deaths here in samsara, we have only ever known the suffering of death, and all these births have been entirely devoid of meaning. But now I will make sure that this present death of mine is meaningful. The process of dying begins the moment we are born. No one expects a baby to slip out of its mother and make a will. But as you get older, at 50, or better still, 40, you should think carefully about what you want to do and achieve before you die. So I'm going to stop there and introduce our first speaker, Annie Whitlock. And I'm just going to use my iPad, I think. There we go. Welcome, Annie. So Annie Whitlock has worked in medical clinics and hospitals for the past 25 years as a practice manager and a lay Buddhist chaplain. As a non-medical death doula, she is with people of all ages as they face end of life. She is a palliative care liaison coordinator for the Buddhist Council of Victoria, Associate Director Social Health Australia, and shares her home with a senior Gyuto Buddhist monk and 5 severely disabled and happy dogs. Welcome, Annie.
Thank you, Anila. Thank you for asking me to be a part of this session with Rachel and Di. I hope you're all well and your life is as smooth as possible. What is a lifetime? When a baby is born and dies a few hours later, that is their obvious lifetime. And I sometimes remind the parents that that baby lived within the womb also, that mum's body cared for her child with her body. When my granddaughter died unexpectedly, 8 hours after her birth, that was her lifetime. There were tears, of course, There were countless unanswerable questions. Why? From the mother. Was it something that I did? Am I to blame? For the siblings, why is everyone acting like this? My son and daughter-in-law are not Buddhists. Naturally, I don't use Dharma talk. Yet there were conversations that required clarity, cremation or burial. Neither of them had ever discussed this for themselves or their children. Baby steps. Dipping the toes into the perceived chilliness of these conversations can be like standing on the edge of an abyss. Yet it hasn't killed anyone to date. For myself, I've had 6 miscarriages. So from conception, I'm reminded of the 5 remembrances. I am of the nature to die. There is no way to escape death. I've been a citizen of this world for almost 70 years now. And one of my deepest awakenings has been the acknowledgement of selective, self-imposed ignorance by resisting and avoiding life as it is. Our society at times encourages this by avoiding talking about the inevitable. I was with a young family in maternity in a hospital as a lay Buddhist chaplain, and their baby was in ICU before there was a specific pediatric ICU. Beside the baby was a man on life support. And the father told me it was an awakening to the reality of our existence. On one hand, his baby being supported to live, and on the other hand, a man who was preparing to leave this world.
Thanks, Annie. So, assuming that some of the people or some of the audience may already have a plan in place, some people may want to review a plan, some people are starting from scratch. What is the first step when we're considering making an advanced care directive? Where do we start?
Gosh, I remember when I started learning about advanced care directives, advanced care planning, it took me so many goes to be able to comprehend it, to get it. And I'm still learning. So for me, the first thing was it's a great act of kindness to ourselves, our loved ones, strangers, family, the medical professional who will help us. You are with strangers. They don't know you. They don't know your values. First, there are advanced care directive departments in most hospitals. You can ring, make an appointment to go there. It's free. Prepare beforehand by going to the online Advanced Care Planning Australia website or Google Advanced Care Plan or Directive and test yourself using their questions. Because at the appointment, you're going to be sitting with a person who knows nothing about you. It will usually be a nurse, which is why it's important to have some thought beforehand. What are your values, your wishes? In the Advanced Care Directive Department, they will send your Advanced Care Directive around to all the other major hospitals, which is really handy. Remember, it's when we're unable to talk. Now, we may never need an Advanced Care Directive. But what if we do?
What if we do indeed? So, when we're thinking about what to put in our wishes, what's important to consider, what's important to consider with our values, how do we get started with that?
That's probably just start to think of how often do we actually think of our values, the things that are important to us. So I use myself as an example. As a Buddhist practitioner, there are certain things that I have actually written down in the values section of my Advanced Care Directive. I would like, if possible, an open window, natural light, chanting, a CD, a statue or picture of the Buddha or of my teacher. I would like 20 minutes of privacy a day, a few times a day if possible for my practice. I like hand, foot, body massage. I don't sleep with a pillow. So if someone put a pillow under my head, I just keep throwing it on the ground. I can't eat broccoli. It makes me sick. After 2 spine operations, I always have a pillow, 2 pillows under my knees. I'm a vegetarian and I don't drink milk. Remember, this is when I am unable to speak for myself. I'm going to be repeating that a few times. A couple of weeks ago, my neighbour died at home. He was about 72. He had a cardiac arrest. His wife called the ambulance and they asked if there was an advanced care directive. There wasn't. Now, these are time critical decisions for paramedics. They attempted resuscitation and it wasn't successful. The man had told his wife many times that he was not to be resuscitated, but it was impossible for her to follow his wishes at this highly stressful time. If he had been resuscitated, he would have resumed his physical and mental suffering. He had been very ill for almost 20 years. His wife kept saying to me, he didn't want CPR, and I couldn't say it. So she felt like she failed him. If she had an advanced care directive at hand or at the front door like mine, as soon as you come in the front door, there's mine, this stressful situation could have been avoided. Sure, call the ambulance, show the ACD, the advanced care directive. They will provide pain control and comfort.
Okay, thank you. So, covered a little bit about values, a little bit about wishes. What did you do when you were thinking about the instructional section of your advanced care directive?
Well, obviously, we're all different. So, my medical instructions are quite clear. For example, if I have been diagnosed with a terminal neurological disease such as multiple sclerosis or Parkinson's, I do not want cardiopulmonary resuscitation or any artificial life support. Now, please remember, this is only when I am unable to speak for myself. If I have a heart attack, for example, I do not want CPR. My grandmother and my mother both had Alzheimer's. And I remember my mother making sure that we took this into account when I helped her with her advanced care directive. I re-look at my advanced care directive every couple of years to see if anything has changed, such as my medical condition or my viewpoint.
Okay. So this is the million evening. Why is it so hard for many of us to actually get on and do our advanced care directive? You know, what is it? What is it that makes people put it off?
Probably everyone's got their own reason. I'm thinking that maybe it's because it's really hard to conceive of us not being able to make a decision about the control of our future or the present. It's inconceivable. But if we have just received, for example, a terminal prognosis, now that's the worst time to contemplate an advanced care directive. Imagine you've just been to the doctor and you've received the shocking news you have a terminal disease that may only extend your life by another 3 months. When receiving a terminal prognosis, even if a spiritual practitioner, when faced with our mortality, we may not always be the best spiritual practitioner. A few days before this diagnosis, perhaps you had trivialized the pain, the discomfort, and now you go back to all the times that your body was speaking to you. Life was demanding. People needed things from you. Perhaps you experienced guilt, and now you are looking at leaving people you love. Perhaps you are angry, confused, in pain, impatient. In that time, you're asked, what are your values? And what are the situations that you would want or not want medically or holistically? That's tough because you're not going to be able to be thinking clearly about a lot of things. What you will be losing, you're thinking of that. You're thinking of how to prepare for this situation, how to fight, the shock of realizing your mortality, losing your loved ones, handling the drug regime and its side effects. So many thoughts, distractions, and emotions. You're not thinking clearly or perhaps even rationally, which is why speaking about your values, the things that are important to you, will be easier to do now when you are well. I'll share an example. There was a Buddhist lady in palliative care. I received a phone call from the head nurse. A daughter wanted a monk to pray for her mum during and after her death because this is what her mum had requested. She knew this, but they didn't know what kind of monk. was it Theravada, Mahayana, Vajrayana, and another family member didn't want this to happen. After some toing and froing, the nurse said a Tibetan monk would be okay. So myself and the Lama head off in the car. Halfway there, we receive a call from the nurse cancelling it because the other daughter refused to have the monk there. We headed back home. If the values and wishes had been documented in an advance care directive with phone numbers of the people that you would like there, I've got phone numbers in mine, that would have been of great benefit to everyone.
Thank you. I think we're getting the picture. It's pretty clear. Um, so, if we're going to have an advocate, if we go down that path that we want to actually have someone be our advocate and be responsible for us when we can't make decisions anymore, how do we decide who to trust with that responsibility? You know, I know for a lot of people they say, look, I just can't get there because I can't decide. And of course we don't have to have someone, but if we're going to have someone, yeah, how do we think about that? How do we think about who to select to trust with our...
There's probably two documents. There's the medical treatment decision maker, also sometimes called the substitute decision maker, whom Rachel will talk about, and the enduring power of attorney. Some people may feel uncomfortable about making decisions for you, and you remind them that they're not going to be making decisions for you, but they're just going to be following your wishes. Start the conversation, let them know what you would want in a certain situation. Ask them, are you comfortable with that? The person that you select must be able to follow your wishes, even if they don't agree with them. They are going to be your advocate. Have these conversations now, a few times, preferably not at the last minute.
Okay, and what if someone actually doesn't have a person they can nominate? They're not in a position to have someone to be their enduring power of attorney?
And there will be people like that, people who live alone. Maybe they don't have family or they don't want them, or close friends, and perhaps they're very private. So this is why the written word is so important, in particular if it's authorized and witnessed correctly.
Thank you so much, Annie.
Mm-hmm.
Now, there's going to be an opportunity for people to put questions in the chat as we when we get to the end of the speakers. Just going to invite Dr. Rachel now. Just bear with us while we get the screen right. Fantastic. So I would like to introduce Dr. Rachel Buckley, who many of you know. Dr. Rachel has been a general practitioner for 30 years plus and has always had an interest in end of life. She has a wide range of experience in HIV, homelessness and working in developing countries. In all of these settings, Dr. Rachel has looked after people as they die at home and many with minimal medical intervention as it was unavailable. Today, Dr. Rachel will share information about the medical aspects of advanced care planning. Over to you, Dr. Rachel. You're muted. That's it.
Am I unmuted now?
Yes, fantastic. Thank you.
Okay. Thanks, Zangmo.
Welcome.
And thanks to Annie, who's given us a really good overview of advanced care planning, and I apologise if there's any repetition. But I'm going to continue with talking about advanced care directives and the potential role of medical practitioners in facilitating a person's wishes around medical treatment and end-of-life care. So advanced care planning began in the 1960s with the documents first referred to as living wills. These days, this term is used more often when one is referring to medical power of attorney or enduring guardianship, which are legal documents separate to the Advanced Care Directive. The Advanced Care Directives come under the umbrella of advanced care planning, but often but not necessarily will involve a medical practitioner. So advanced care planning continues to develop with an awareness of contemporary autonomy, that is, a person's right to make decisions for themselves and express their values. And the Advanced Care Directive attempts to preserve that autonomy so that if a person has lost capacity and can't consent to or decline medical treatment or communicate their wishes, we have that document and their surrogate decision makers. So the simplest way of thinking of an advanced care directive then is it's a letter from you to your future doctors and healthcare workers about your desired approach to medical treatment and end-of-life care should you lose your decision-making capacity. And I think Annie's driven that home. So the factors that influence advanced care directives and lend them increasing relevance in these times are the rapid advancement of medical technology and life-prolonging medical treatments, together with an ageing population that have increased longevity and an accumulation of chronic degenerative health conditions and disabilities. In particular, our ageing population suffer from rising rates of associated cognitive impairment, especially dementia. And these are the things that can impair a person's ability to make real-time decisions about medical treatment at the time of their dying phase. So one can see in our modern situation, the ethical and value issues specific to the individual are often more relevant than medical and legal precedents about preserving life in life-threatening medical events and end-of-life care. And we all know that all that lives must die. So it becomes very important to weigh up everything in a crisis situation. So if the principle underlying advanced care directive is to retain autonomy, if someone loses capacity to make decisions about their care, one should know that the advanced care directive will only be used when you're in such a situation. As long as you can make decisions, you won't need to rely on your advanced care directive. And generally, especially here in Australia between the states, there's an agreement by both medical and legal professionals that a valid advanced care directive must be followed. So to talk a little about the content and format of advanced care directives, there's obviously a profusion of different formats available for perusal online. An advanced care directive can be simple with value statements, heavier on the value statements rather than specific preferences, or it can be very specific and instructive with documented instructions to consent or refuse specific treatments such as cardiopulmonary resuscitation, assisted ventilation, artificial hydration, artificial nutrition, and antibiotics. There's also very many different terms used throughout advanced care planning. But basically the legal formatting of a valid advanced care directive will depend on the jurisdiction in which you live. So we encourage you to research what is available for you. Commonly, advanced care directives will contain your needs, values, and preferences for your future care, plus the details of a nominated substitute decision maker. And I think you've already heard Annie refer to a medical treatment decision maker, which is the one that appears on the Victorian Advanced Care Directive. And a previous term used was surrogate decision maker, but the general consensus seems to be moving towards using a substitute decision maker as the term. So the issues that may be dealt with by the substitute decision maker could be consenting or not to medical intervention in a crisis when you are not competent. So, for example, if there's someone who has underlying advanced stage cancer, they might have a acute deterioration with reduced consciousness from an infection in their lungs, which is potentially treatable. So this is a common scenario in end-stage respiratory failure, and the decisions of the substitute decision maker whether to consent to aggressive treatment of the infection with antibiotics or not will be a reflection of your wishes dependent on your expressed wishes and values you have discussed with them, as well as those recorded in your advanced care directive. So as I alluded to, in Australia, every state, and New South Wales is actually an exception, has a specific act of parliament that the advanced care directives come under. And each state or territory will have a differently formatted advanced care directive that the government's published for suggested use within that jurisdiction. You can find that online with an accompanying instruction booklet explaining approaches to the questions that deal with values directives, as Annie was talking about, and medical instructions, which are all around the end of life care and different medical interventions. So I'm going to speak now just to the potential benefit of involving a medical practitioner in making your advanced care directive, because remember, it's not necessary for you to do that, but it does have some advantages. Perhaps the most apparent one is that the medical practitioner can witness a directive, and this nails down the issue of competency in the event that there's a subsequent challenge around cognitive decline. So in Australia, it specifically recommends that the advanced care directive, however it's done, it should be completed with a registered medical practitioner so that they can sign, and their signature implies that you had capacity at the time that you filled out that directive. And say if there's a person who has been diagnosed recently with early dementia at the time that they're completing their advanced care directive, the doctor can add a specific clause emphasising the competence of them on the witnessing date. So the registered medical practitioner will have access to your medical history so that they can discuss possible outcomes around relevant health issues that might arise for you around end of life, and what circumstances might trigger the enactment of your advanced care directive, such as someone with respiratory failure having a very serious infection that might be the termination of their life if it's not treated. So for those patients who have a specific chronic degenerative disease, many are managed in specialist medical units, and here they have increasing access to tailored end-of-life medical care information relevant to their advanced care directive. So for example, in a dialysis unit for people with chronic renal failure, the advice can be given if you want to know under what conditions dialysis it might be good to stop dialysis and include that in your directive. So in these specialist units, it's sort of interesting that palliative care doctors are starting to consult with the patients who are suffering with advanced disease, and they're in renal, respiratory, cardiac and neurodegenerative units. They're starting to pop up, and they're there to integrate end-of-life care as those patients progress towards the dying phase. So for some people, the registered medical practitioner who knows them and their families the best will be their general practitioner or family doctor. So the GP is often already coordinating medical care when there's multiple chronic issues, coordinating that care across your various specialists, and they're well placed to promote patient autonomy and support decision making in situations where specific ethical considerations arise. Ideally, the general practitioner can discuss the nomination of a substitute decision maker with you, and they'll have some knowledge of your cultural, social and family background maybe. And when the person does nominate either one substitute decision maker or sometimes a group of substitute decision makers, the doctor can often have the opportunity to facilitate agreement between individuals and their substitute decision makers around specific instructions. So a notation can be made, once again, a separate notation on the advanced care directive that allows the doctor to be included in discussions with a substitute decision maker if they feel they require support in making decision in a crisis. So one of these things that might come up with Buddhists is the use of sedation and painkillers in the dying phase. So some people may want to specify instructions around this situation in their advanced care directive with statements such as, when I am in my dying phase, if I become agitated, I'm happy to have proportional medication given. And you could add, if I am in this situation, I trust, and then put in the name of your nominated medical practitioner or the substitute practitioner you've had extensive discussions about this with. I trust this person and would like them involved in medication decisions. Or you could give a very definite instruction, which would be, should I experience agitation in my dying phase, I do not want any other sedation or pain medications given to me. So another issue for Buddhists is often organ donation. So I think Di is going to speak to that after me. So, but it does appear on a lot of those advanced care directive forms where you can consent or decline to be an organ donor. So your advanced care directive will better reflect your values if the doctor assisting you is someone you trust and feel comfortable opening up to about your fears and expectations. This gives them the opportunity to address them and assist you in translating your wishes into your directive. So back in the early 90s era of AIDS, I was doing seminars at the AIDS Council of New South Wales for people living with HIV called How to Choose Your Doctor. And the message remains the same. Try to find someone who demonstrates patience and attention as you are contemplating your wishes for end-of-life care. And from my experience in this area, people do expect doctors to have expertise, but they really yearn for their kindness, the doctor's kindness. So the journey to advanced care directive is often stepwise, with patients picking up more information about their medical care and the interventions that they might face as they interact with other patients and discuss their own disease progression with healthcare workers. And then at some stage they're ready to do complete their advanced care directive, and that's where they'll go to their chosen registered medical practitioner to do the signing. Once your advanced care directive is finalised and signed, your GP or doctor can scan it to your file at the practice, forward it to the treating medical specialist. And here in Australia, we have an electronic My Health record. They can upload it up to there, so it's going to be available to you when you present to any emergency department or hospital or see other treating healthcare workers and give them permission to access it. You can distribute it to your friends and family, including any substitute decision makers, as well as keeping a copy on the refrigerator or, as Annie said, at the front door for easy access if the ambulance is attending. And Advanced Care Planning Australia also have an Advanced Care Directive wallet card that you can print out, alerting others that you do have an Advanced Care Directive, you wish for it to be respected, and giving the contact details for your GP and substitute decision maker to facilitate contacting them. So the last thing to remember, and Nanny's already said it actually, is that an advanced care directive can be changed or revoked as often as one wishes, as long as they have retained decision-making capacity. But you have to remember, if you're doing that you'll need to get it updated in all those various locations that it's been lodged. Yeah. So thank you for that.
Wonderful. Thank you so much. It's really helpful hearing some of those specifics. And we will, again, people can have the opportunity to put some questions in the chat box at the end. But for now, we will continue. And we've also got some resources that we've put in the chat box, and I'll say a bit more about them as well, because there are so many resources out there. So I'm just going to find, well, Shempen's just going to find Dr. Diana to screen share her with me. Fabulous. So I would like to introduce our last speaker for this session, Dr. Diana Cousins, Dr. Diana Cousins has a PhD in Himalayan Studies from Monash University. She's the Vice Chair of the Buddhist Council of Victoria and a long-standing student of Zongzo Khyentse Rinpoche's. She is the Australian representative for the 84,000 Project and publishes on the Tibetan treasure tradition and engaged Buddhism. Her publication, Buddhist Care for the Dying, 2004, is a standard text used in Buddhist chaplaincy in the healthcare sector. She was the foundation president of Sakyadita Australia in 2016. Welcome, Dr. Diana. Diana's going to present part of a paper that she wrote for the Sakyadita conference this year. So she's very kindly abbreviated it for us. Over to you.
Yeah, thank you. And it's a great honour to be invited, and always an opportunity to learn a lot from Annie and Rachel. Contemporary modern medicine has made organ donation a possibility. This is a topic that Buddhists need to consider, as the donation of an organ is a form of generosity and may be life-saving. However, there is not a single unitary view about organ donation among Buddhists. The views vary according to the division of Mahayana and Theravada, and are also informed by ideas about the stages of death. In Australia, we have a system of collective representation of Buddhist temples in the form of state-based Buddhist councils. These councils provide a voice to government on topics of concern and a public face for such things as interfaith dialogue. I am the Vice President of the Buddhist Council of Victoria, and in 2020 I liaised with a group of hospitals called Western Health to promote a new protocol on organ donation for the Buddhist community. It was adopted at the annual general meeting of the Buddhist Council of Victoria that year and can be read on the website. The adoption and publication of the protocol enables an informed discussion by both patients, their loved ones, and medical staff. Examples of organ donation can be discovered in some very old Buddhist texts. It is the tradition that the historical Buddha, 500 BCE, achieved a stage of perfection after many lives practicing virtues, including generosity. And the stories of these previous lives are found in the Jataka tales. Sometimes this generosity involved cutting off a part of his body and giving it to others. One of the most famous stories is of how he cut his body and fed it to a hungry tigress who had starving cubs. The shrine of Namo Buddha in Nepal is regarded as the location of this event and is a pilgrimage site. Another story from the Buddha's past lives is of when he was born as the king of Sibi. A blind man approached him and asked him for one eye. The king offered both his eyes. At that point, the blind man revealed himself as the god Indra, who gave blessings to the king for his intended generosity. These past life stories of the historical Buddha show the journey of the Buddha prior to enlightenment and demonstrate how he accumulated the necessary merit and wisdom to become enlightened. These great acts of generosity were a part of creating the causes and conditions for his final rebirth. Therefore, the idea of donating parts of your body to help others is deeply entrenched in the Buddhist tradition. Among Buddhists from Thailand, Sri Lanka, Burma, and others who follow the Theravada tradition, there is likely to be no objection. It is simply a matter of personal choice. On the other hand, issues arise around organ donation for the Mahayana Buddhists of Vietnam, China, Japan, Korea, and most especially Tibet. Questions arise because of beliefs about the journey of the subtle consciousness of a person, which is thought to travel from this body and this life into the next one. It is believed that a calm, smooth transition is helpful so as to achieve a good rebirth. Having your body cut open will upset the consciousness, and this distress will make it hard to have a good rebirth. Of course, there is an assumption here that a person has a slow and observable dying process. A person who dies suddenly in a car accident or as a result of a violent attack will not have the graduated process that is idealized. There are also questions about how much bodily awareness a person has after brain death. The idealized dying process is where monks and nuns chant in the room at the time of death. There is no disturbance from crying relatives, and the person has given away all of their possessions. The body is undisturbed for 8 hours or longer. While Western medicine declares death as brain death, the Mahayana, and especially the Tibetan tradition, considers that death has many stages. Brain death, particularly with the heart still pumping, does not look like death to Mahayana Buddhists. To give a quick overview of the dying process as understood in the Tibetan tradition, it involves the following 4 stages. Buddhists believe that everything changes, nothing stays the same. The term bardo is a Tibetan term meaning in-between state, a state that is not fixed. From the perspective of the Tibetan Nyingmapa and Kagyu traditions, even this life is an in-between state. I received these teachings from Choki Nyima Rinpoche and Ogyen Tulku in Kathmandu in 1987. The first bardo is the bardo of this life, from birth until the time when a person starts to die. The second bardo is the bardo of dying. This is the stage from acquiring a fatal illness to actually dying. The third stage, the bardo of dharmata, is the stage where the consciousness and other subtle characteristics of a human being make the transition to the next life. The fourth stage, the bardo of becoming, occurs where the luminous nature of mind is accessible but not recognized. The person arises separately to their deceased body in a subtle form that is aware of the old surroundings, and they seek a new rebirth. During the bardo of dying, the body becomes cold, a person becomes confused and experiences a range of visions. Their consciousness dissolves into space and breathing stops. Those who have practiced meditation and who accept the dying process experience less suffering. They experience space dissolving in luminosity as all the components of the mind become purified. This experience has names like the great original state of primordial purity. Those who retain an awareness and an ability to concentrate during this process will have the opportunity to realize the nature of mind at this time, as the mind is in its essential state. For some Tibetan Buddhists, organ donation is problematic because it interferes with this stage of dying. This is a large topic of discussion, and many traditions require 8 or more hours of chanting after death, at which point only a tissue donation would be possible. But tissues include eye corneas, so such a gift could enable a blind person to see and is a significant help to the recipient. Tissues can be harvested up to 24 hours after a person's death. This would be achievable and also enable the required amount of chanting. In addition to the practicalities of organ donation, the Buddhist Council protocol specifies that the donor should have identified themselves during their lifetime. In that way, no one has to guess what their wishes would be. We need to start talking about organ donation and identifying ourselves as donors or as not donors. Either way, loved ones need to be informed. And if you live in a country where you can join an organ donation register and you wish to be an organ donor, then please enter the register without delay. It is worth noting that even in spite of all these concerns about the consciousness at the time of death, I am aware of a very senior Tibetan Lama and ritual master in Victoria who has registered as an organ donor. Another important life-saving gift that one can make in this life is blood donation. In Australia, you can donate blood 3 times a year if you are in very good health. To return to organ donation, there are a huge number of complex questions relating to living donors, and it is a serious problem that people may be pressured by their relatives to donate their kidneys, for example. No one has any spare organs. No one should be pressured into making an organ donation, and all living donors must receive the same standard of care as donor recipients. Our Buddhist Council protocol includes the statement that living donors must have a Bill of Rights and an advocate to determine that they are not being exploited. The topic also points to a number of other issues. Organ donation is a very expensive and complex procedure, and it is useful to note that primary care, particularly the care of mothers and new babies, is often underfunded. Also, organs may fail because of a lack of preventative care or because of lifestyle illnesses like type 2 diabetes. In a world where there will never be enough organs for all, it is useful to remember that the historical Buddha founded his religion on the observation of the reality of old age, sickness, and death. No amount of new organs will ever ultimately beat death, and it is a Buddhist perspective that those who have an attitude that accepts the impermanence of life will experience a better death. Thank you.
Wow, thank you.
Thank you so much. So what I'd like to do now, Shempen, would you be able to spotlight me with, going to invite myself, Diana, Rachel and Annie, and I'm just going to read in the chat any questions we might have. So I know we're going to go over time slightly, but just an opportunity for a few questions. So I'm going to have a little look what's come up here. So we have, what is the situation of people lonely, dying in their homes? Is there an organisation that is going to take care of them? In my country, I don't know of such an institution. So which country is this?
Stanislav. Who's Stanislav?
Bulgaria. Okay. Yeah. So, I mean, we can't speak specifically about Bulgaria because we don't have that knowledge, but maybe maybe there's a way that you could get information about what's in your country, what services are there, perhaps through the hospital. I mean, I'm just guessing, Dr. Rachel, Annie, you might have some ideas around how to ascertain what would be there.
Well, initially, I think straight away what palliative care is available, and as I don't know what is available in Bulgaria. Then there is the community. I think as a community, when we are aware of our neighbour or someone that is close by who is very ill, nearing end of life, to make ourselves known, to see if we can be of service to that person.
Mm-hmm. Yeah, okay. There was a question a bit earlier. Would wearing a wristband about not wanting CPR be helpful to the paramedics in case we have a car accident? Diana did make an answer yes, or you could have a card in your wallet. Any other response to that?
I forgot to actually make a quip about how I've worked on and off all my career with heroin users, and the amount of them that have "do not resuscitate" tattooed inside their lip is just unbelievable, you know, DNR or "do not resuscitate." So, but yeah, a wristband anything that makes you, you know, depends how, what your situation is, but especially if you're approaching end of life, I think that's a great idea.
Yeah, okay. Thanks, Dr. Rachel. So, I've got one missing here. How can we embrace death and not fear it? It's a very big question. We need a little buzzer so you can each go boom, boom, boom.
I think Di said it, no? Like, the more you appreciate impermanence and really pay attention to everything around you, because everything reinforces impermanence all the time, then the easier it is, I think, to look at death. Just not to shy away from, but the true nature of everything is really impermanent, and we have to appreciate it while we can.
Then there's all the little deaths that we see throughout our lives, and so many things that we thought that, you know, life was always going to be like this, and then it changed, and then we have to readapt and reinvent. And I think that's just a reminder of impermanence. But I think the more that we start talking about it, and there's some beautiful, perfect Buddhist practices that we can start saying daily. I mean, I don't know what I'm going to feel at the time of my death, but I hope that I'll be okay because I'm working on it now.
Yeah, and it's also the idea of not just change, but continuity. Like, you know, so from a Buddhist perspective, this is already a subsequent life, you know. It's not like this is your first life. So it's not it's not the case that you're looking at cessation of everything. It's a matter of a change of clothes.
Yeah, great. Thank you. So we're going to do two more questions quickly. This one is directed to Rachel. For Buddhist practitioners, which pain medications are okay if one wants to remain as cognitively present and aware as possible as we die?
I think the big awareness at the moment is that a lot of people have a lot of misconceptions about pain medications. Obviously, around end of life care and in your dying phase, you're not worried about being addicted. And it's not so much that one is better than another, I think. It's more that the pain medication is proportional to whatever the pain is that you've got, you know, and that you have control over it. If you're have got capacity, otherwise that your substitute decision maker has some idea about, you know, whether you want to be made comfortable or whether you're insistent that you don't want any medication, because pain leads to agitation, and palliative care doctors and people who assist people to die will say that sometimes it's really for the relatives that palliative care doctors try and be careful to give proportional medication so that the relatives don't believe that the death is being hastening, because it's just not really something that happens these days in that situation, that the pain medication is hastening death. But also that people relatives don't have to see their loved ones in complete agitation, you know, completely distressed, because from their experience, from our experience, it just makes the bereavement phase far more profound, yeah, and confusing for people. So it's a matter of weighing up all those things. So that's why it's good that you have your say if you have particularly strong ideas about it, and certainly discuss pain medication with people if you get the chance, you know, who are likely to be around at the time of your death.
Yes, thank you. I think this last one could be for you as well, and it will just be a quick one. I've had these discussions with my partner already, but I'll get something written now, especially after seeing our sister pass recently. What are the exceptions for New South Wales that you mentioned?
Oh, only that in New South Wales there's not actually an act of parliament, which doesn't really mean anything, because there is a published advanced care directive, and it does have a similar format to some other bands. In fact, it's a little bit more detailed than the Victorian one. I think the important thing is to remember if there's any possibility that, and it's not that someone really wants to challenge the directive, that may not even be the case. They might want to challenge the will afterwards by saying that the directive is, you know, um, hasn't taken into account that the person was in cognitive decline. So having it witnessed by a doctor is a good idea if that's the situation.
Fantastic. Thank you so much. Lizzie's just put a link in there, but what I'm going to do now, there's some other links in there which I'll mention at the end. There's just one part of the book that we actually need to finish on, and then I'll mention the links, and we can dedicate together. But thank you so much to each of you for being here tonight. It's been really wonderful, really great information sharing. Thank you.
Thank you, thank you, thank you.
Okay. So I'm just going to share the section that we finish on to bring us up for next week. Very Rinpoche. Live life to the full. Try to enjoy your life. Go to Machu Picchu or Madagascar or wherever you have always dreamed of visiting. Be realistic about what you need to own and buy. Ask yourself, do I really need another Ferrari? Do I really need that much money in the bank? Remind yourself that taking care of expensive toys and bank accounts often creates more stress than joy. Unless, of course, you take great pleasure in philanthropy and are planning to put your abundant cash to good use. Start to look at and relate to everything and everyone around you as if you were seeing them for the last time. Deal with all the outstanding problems or disputes within your family and among friends. Now is the time to sort out any misunderstandings and resolve lingering bad feeling. Above all, the best preparation for death is to live a full life. Enjoy the most delicious tea in the world, made properly and not drunk out of plastic cups. Wear the clothes you have always longed to wear. Read the books you have always wanted to read. Do everything you have always wanted to do, however outrageous or obnoxious. And do it now, because you may never get another chance. So, what we have put in the chat at the beginning of the session, there's a number of resources, and they will also be available on the website. So we have a link to the ACP Australia, which has information about advanced care planning and what happens in each state, how to access the paperwork in each state. Of course, I'm aware there's people here from different countries, so you would need to find your paperwork for your country. We've included a New South Wales specific form, which Dr. Rachel showed me, which is very detailed. So there's a lot of prompts in there that people might find useful. I've included a link to Karuna Hospice up north, and they have so many different what are they called? I can't think of the word, but anyway, it's different pages, different information pages, and one of them is your wishes before you die, a checklist. Your wishes as you die, there's a checklist. Your wishes after you die. So great resource again, just to have a look at. We've included the link to get the little form that you can put in your wallet to say that you have an advanced care directive. We've included a link to Dr. Diana's paper on organ donation. It's actually part of the Sakyadita newsletter, so we've put the whole newsletter in there. And the book, the little booklet that Dr. Diana did, The Buddhist Care of the Dying, that's included. Another link to a book called The Bottom Drawer, which is just a delightful overview of everything to consider with your death and after death. And also a link to Buddhist death cards and games. So if you're looking for a new Monopoly, there's plenty of options there. So yeah, all of that will be either in the chat here for you. Well, it was placed in the beginning, or it will also be on our resources page. And Annie Whitlock and myself are happy to be contacted if you have any questions, any sort of information about where to go from here. And then I'll direct your queries if they need to go to Dr. Rachel or to go to Dr. Diana. So the links were put in at the very beginning of the chat. Someone's saying that they're no longer there. So
They aren't, Zangmo, Ani Zangmo, I can't see them either.
okay, so they've vanished. They were on there. They were put on there very early. So maybe
They're still on there. They are still on there, right up the top. You just got to scroll up.
Okay, so what I'm going to do now, just so we can finish, is do our dedication together. So maybe just having a look while I'm getting my dedication. Checking if you can find what you need to in the chat. Okay. Yeah, a lot of people are saying they can't see them. Okay. Let's dedicate together. We'll deal with the missing resources in a moment. This virtuous accumulation of merit we offer so that all obstacles dissolve, and that at the time of our death each of us may find ease in dying and swift rebirth in the pure land of great bliss, quickly gaining enlightenment for the benefit of all sentient beings. Thank you again. Apologies for those that can't find what was in the link. We don't have time to paste them all again now because there were like 8 links. I mean, we can actually. Annie Shempen's just trying to post them. So if you want to stay on, we can do that. But also, they will definitely be in with all of the resources. Yeah. Okay. Fantastic. I'm just going to stall for a bit longer then while they go up. Do you want to wait while they're all getting put up, or are you happy just to get them from the resource folder? We're going to wait. Excellent. So we can have a little hello then. Hello, hello, hello.
Thank you, Zangmo. I need to go. Thank you so much for the panel members.
Thank you.
Loved it.
Okay, bye-bye.
Yeah, thank you, everybody. It's just absolutely wonderful what you're doing for us all. Thank you again. Bye.
It's a great team. Oh, I forgot to say, actually, that's my mistake. What's coming up next week? Next week we have the Om Mani Padme Hum mantra and also Bardo. So Jakob and Jungchup, I think, will be speaking next week. Yeah. Okay. Is that all of them, Annie Shempen?
Just the cards. That there are a lot of them. So
okay. Yeah.
Anyway,
please, everyone, go to the Living is Dying resource page, and you'll have everything there. I'm just going
Thank
to.
you.
Thank you.
Thank you.
Thank you.
Very helpful.
Thank you.